Welcome everyone. This is Paul Grady, one of the Moving to Value Executive Committee members. We're happy to have you here. So for those of you who don't know me, I work with employers to help them manage their benefit plans. And this slide illustrates one of the reasons why Moving to Value was formed. Just the steady increase in employer healthcare costs. For the last 20 years. This week, I presented a renewal, health insurance renewal for one of my nonprofit clients, 1,000 employees, it's a nursing home, and the increase that they're facing is 19%. They're struggling with how to manage that, as you can imagine. And unfortunately, those kinds of increases are much too common. So if we go to the next slide, please. Some of us have been working to improve healthcare value for many years. But what we've learned is that employers can't fix the healthcare system alone. And this article just talks about the work that some big employers have initiated to improve healthcare, and they just can't get it done by themselves. So if we go to the next slide, our goal of the Moving to Value Alliance is to bring stakeholders together from across the healthcare ecosystem, employers, providers, insurers, and we want to work together to improve the healthcare system. So if we go to the next slide, please. This slide just illustrates our organization. John Rodas is a convener. We're going to hear from him, and the names of the executive committee and the kinds of things that we're focused on. Our annual Moving to Value Forum is going to be June 2nd and 3rd, and we have Elizabeth Teisberg committed as our keynote speaker. So you'll see more about that from us later. And we go to the next slide. So all of us that are on this webinar know that there are lots of opportunities to be better, and we need to be better. What Moving to Value likes to do in webinars like this is to expose each other to people who are actually executing in the move to value. And today we have three presenters who are successfully improving value in the healthcare system. And I'm going to turn things over to my colleague, Dr. John Rodas, who's going to introduce our speakers.
Thank you, Paul. It's really a privilege for me to moderate today's session. And I think you're all going to be very excited to hear from our speakers, who are just incredibly smart, innovative, and have really come up with, are coming up with creative solutions to deal with the healthcare really crisis that I think Paul just articulated. So I'm going to jump right into it. Our first speaker today is going to be Ian Chiang, who's a partner at Flair Capital Partners. I'm just going to give a brief intro, although I could spend an hour introducing each one of these guys. Ian and I, the only thing we have in common is we both went to Cornell. He got his BS in biological engineering. Then he went to Harvard Business School, got an MBA, worked for McKinsey for about 5 years, advising healthcare clients across the globe. And then he went into the entrepreneurial world, started a company called XLDX, which ultimately got, I think, partnered with Scanwell Health. It's a smartphone-enabled diagnostic company that was eventually acquired by Becton Dickinson. And I think then you worked for Ian, you worked for Becton Dickinson for a while, doing product innovation, leading their product innovation team. Then you moved on to Cigna, where you ran U.S. strategic operations for them, and eventually formed a group of Care Allies, which is a Cigna's family of multi-payer provider services, population health, management, home care. And then finally, Ian has now moved on to become a partner at Flair Capital. So Ian, it's a pleasure to have you here today. Thank you so much for joining us. Tell us a little bit about Flair and what you guys do.
Thank you so much, John. Your intro is way too kind. I probably, maybe as my wife would say, I have ADD and just keep on moving from one company to another. We're building one company, and then eventually, I think for the past almost 3 years, I landed my one of my perfect jobs, which is being an investor. Get to see companies all across the board and partnering with aspirational and phenomenal entrepreneurs like Sam and Dan. Actually, in full transparency, Flair invested in Oshi Health. So, and of course, Dan and I were classmates in business school. So maybe one day we can also partner with Dan and be an investor. So Flair, just a very high level overview. We're a Boston-based venture firm. So about 8 years ago, when the two co-founders of Flair, Bill Geary and Michael Greeley, came together after the passing of the ACA. So at the time, there's not many of the investment firms were looking at investing in digital health or health IT. Many of the company, I mean, at the time, probably when you ask people about health IT, people think about EMRs. So when Michael and Bill put together Flair, it was perhaps, I think, the first dedicated healthcare fund that focused on investing in the space called digital health. So Flair, across the years, we manage about $500 million of assets. We focus on early stage investments. So typically we invest in company from seed all the way to Series B. So our typical check sizes could range from a few low single digit million up to $10 million. We prefer to lead rounds. And when we lead the rounds, we partner with the entrepreneurs to help continue to build and scale the companies. And of course, as an early stage investor, for every dollar we invest, we put up like about $2 to $3 as a reserve. So we will partner with the company throughout the life cycle. And some of the value add we also provide, in addition to most of our team members, and many of them, including myself, had prior operating experiences or even co-founders of companies. But we also have a very broad, kind of ecosystem. So some of our executive partners at Flair, I won't name them all, but some of the names many of you might be familiar with. So Dr. Gary Gottlieb, who used to be the CEO of Partners Healthcare, is one of our executive partners. Chris Hocevar, for many of you in Connecticut, may know Chris from his days as a leading Cigna commercial in the US. So we have folks, in addition to our investment team, we brought to partner with our entrepreneurs to help build bigger companies. And also we're privileged to have many of our, a significant amount of our capital comes from our investors, the LPs, are industry strategic. So some of the largest health systems, some of the largest health plans, while we usually don't name them in the public space, but 3 of the top 5 payers, as well as many of the well-known health systems around the countries, as well as other healthcare providers in the med device payer space, biopharma space, are partners of ours. So that's Flair in a nutshell. Today I'm privileged to be here. Of course, you all probably want to hear the real innovators, like so Dan from Novocardia, Sam from Oshi Health, really driving and creating solutions to bring things into value. I will share a few things, maybe just a few observations we have seen here on the investor side, and how things have evolved over the years. And I'll go through them fairly quickly, just so that you can, we'll save time for you to hear the real operators speak, so Dan and Sam. But a few of the things I would say, we're starting to see the decentralization of care, and only, some of that is enabled by the needs, the necessity, especially as we went through the past few years, like with COVID, when the health systems, the acute care settings were shut down. So we as an industry, we innovated. And so the adoption of virtual care or telehealth has gone, like it went from almost zero adoption or incremental adoption to overnight everyone uses telehealth. So that was very encouraging. But as part of today's discussion, we see value-based care and value-based arrangement as a tailwind, and also fundamentally like changing the landscape, right? So again, as a former, I spent years at Cigna launching Care Allies, and maybe one thing I will highlight for Care Allies, for those of you know, in case you don't know it well, like Care Allies is a multi-payer value-based care enablement platform, partners with 60 plus IPAs across the country. And when I was there are about $2 to $3 billion of risk revenue flowed through the Care Allies platform, partnering with the 60 IPAs, right? So even as the former SVP of product, so leading the product team at Care Allies, I was able to see front and center as an operator, and also partnering with the vendors with some of the solutions we built internally, really we were only able to financially justify many of those investments due to the value-based care arrangement. So personally, I'm quite excited about where we're heading from at the macro market, but also together with the CMS and the private sector, really pushing, innovating the way we deliver care. So maybe at a very high level, we're starting to see over the last few years, probably goes without saying, that virtual care or virtual first care delivery is becoming front and center. And many of the virtual-based company born out of necessity, but also born out of just frankly consumer preferences, right? So many of us, like me having 2 kids and a family and a reasonably demanding job, like would prefer to see my physicians, like if possible, like via telehealth platform first before I have to go in for in-person exam, right? So some of the emergence of the digital first, be it primary care or care navigation platform, every single large health plans, or even some of the platforms out there like Accolade and Quantum have all been, getting a lot of traction from the employer space. But I think some of the things I would love to focus on maybe are some of the areas of potential emergence where we are getting really excited. When I was at Cigna, I remember for years, like when we look at the commercial book of business, this is public, like Cigna even published this like 6-7 years ago. It's like 58 or 60% of the overall medical costs actually came from a handful of specialties, right? So if we, as we're looking to move towards value, deliver higher quality of care, like meeting the quadruple aims, like the ability to address the specialty like cost is going to be important, right? And the virtual and decentralized or virtual first care delivery model will play front and center to that. Several of the observations we have, some of the observations we have seen, obviously, over the years, we're seeing that the market has evolved quite a bit, and there's a lot of investments that are going into digital health or virtual first healthcare platform. So as I mentioned, Cigna, when I was there, like it published 57% of the medical spending came from a handful of medical specialties, right? Cardiology, GI, OBGYN, oncology, orthopedics. And of course, that's probably due to the heavily commercial mix of Cigna. But if you go across, depending on the employers or even other health plans, like be on the MA side, like the mix is maybe outside of OBGYN, like MA members probably wouldn't have as much of the spend, but those are high cost specialties are the ones that we need to continue to manage and then also deliver much better care in order for us to maintaining and controlling our overall total healthcare costs, right? Medical expenses across the country. we are starting to see many of the companies that are starting to focus virtual first. So some of the more direct to consumer companies like the Roman Inns or 30 Madison started by focusing on direct to consumer, but many of them are slowly moving towards more on the B2B2C side, or could potentially enable value-based care in a way that, because of their engagement and mind share of many of the consumers, the patients. So many of these companies will continue to play a very important role. The second, kind of category we see on the investment side, and we're actively making investment. As I mentioned, we invest in Oshi, but many of these companies we would love to find different ways of investing and partnering with. Is really the virtual specialty. I think I will let Sam and Dan share what they're working on. Where we have seen is for generation, there's specialty trying to augment the existing provider system. However, there's still just a lot of unmet needs, right? Because oftentimes if there's a 3-week wait time, oftentimes the patients will just find different ways of getting care, right? So many of these companies that you're seeing, be it enabling the provider by wraparound services or directly becoming the provider, be that gatekeeper and offering the ability to prescribe. I think that's also becoming quite an emerging trend over the last several years. And then also on the specialty side, I think there are a number of innovative companies that are trying to enable the primary care to do more, right? The e-consult platform. Dan Blumenthal and I actually went to school. We were the same year, same class with the founder of Rubicon, MD Gill. So having seen some of that front and center, of course, Rubicon recently was acquired by Oak Street Health. So you're starting to see the convergence of primary care leveraging tools, be the one in the second category or just e-consult, to be able to treat more of the patients on the specialty side. And then if we look at the overall rising costs, right? So much of that, in order to get to value and managing the costs, and for any of the providers taking a delegated risk, managing downstream costs is also quite important. And then as the care is becoming more and more decentralized, I think over the last several years, or maybe even the last decade, we're also starting to see care starting to decentralize. It's almost like Clayton Christensen was one of my professors at Harvard Business School. 10 years ago, we talked about care being decentralized, going to the home, going to the retail setting. I think we're starting to see that. We already saw the decentralization of that. So going from many of the urgent care, ER care, or complex care delivery being done at the homes, by Landmark, Dispatch, and others. But also we're starting to see some of the more specialty, a high cost specialty. So another one of Flair's portfolio company, Kayaba Care, is now bringing in the OBGYN care to women who are at high risk of, we all know the US maternal outcomes were among some of the worst in the developed nations, which not only it's a very unfortunate for both the patients, but it also adds a ton of cost into the system. I think 60 Minutes several months ago had even a segment just on preterm birth. The cost in Northern California is $600,000. In Southern California, it's $300,000. In the segment, it highlights the differences in the pricing, but ultimately what we really wanted to do is to avoid as many of the preterm births, right, as possible. So it's not 300 versus 600. It's 0 versus any of the hundreds of thousands. So innovators like the Kayaba Care or City Block are now bringing the much needed care to historically underserved population. And they are all enabled by, some of the technologies that are remote patient monitoring, home-based diagnostics. As John mentioned, I was part of a company that evolved into Scalable Health, which was acquired by Becton Dickinson, which is taking point of care diagnostic to the home, right? So we're starting to see interesting and really, really exciting trends happening in the market. And this is not obviously not an exhaustive list. I take out some of the mental health as well as women's health, because on any of these categories on its own can potentially fill multiple pages. But we're starting to see, as I mentioned, some of the high cost specialty areas, right? So we're starting to see emerging companies in the digital health space, and not only weren't able to build a business model perhaps 15, 20 years ago, but with the rise of value-based care, as well as the overall needs from today's market, as well as consumers' preference moving towards virtual first, many of these companies, including the two other speakers later today, were able to build companies that are truly meeting the needs and then to achieve the quadruple aims. So I know this is a very high level short presentation, but I just want to share what we are seeing from the investor side. And then, and of course, I'm sure you're all eager to hear from the real operators who are leading these changes on the day-to-day basis. So John, I'll hand it off to you.
Ian, I think we need to schedule a whole forum, and you could talk more about all of these companies that you guys invest in and are helpful. It's a fascinating, and it's a high. And by the way, I have to say parenthetically, as a high-risk OB guy, I applaud the efforts because it's kind of shameful, actually, our history in this country regarding maternal mortality, preterm birth, and it, of course, it ties into the whole disparities in healthcare, and we should be ashamed. And I'm glad people are addressing it. It's kind of sad that it hasn't come through the organized healthcare systems. With that in mind, if I can, Ian, how does Flare seems a little different to me. There's billions of dollars obviously being poured into anything that's got the word healthcare or digital health in it. It seems like Flare is a little bit different. Tell me where. And when I called Bill, Mike Greeley, by the way, to say I needed somebody to speak, he said on payment reform, he said, no, you got to call Ian because he's my payment reform guy. So tell me, I understand virtual first. It's certainly better access for patients. It's easier, it's more convenient. Tell me, where does payment reform fit into that? And then if you can, just when a company comes to you or an entrepreneur comes to you with an idea, those early, what are the common threads or themes you see? Because you have a diverse portfolio of companies you've invested in. It's kind of two questions embedded in there.
Yeah, and John, those are great questions, and I'm not sure if I will be able to sufficiently answer that because all of them are evolving, but maybe even I will share some different things we see, right? Just overall on the payment reform side, I think of course, we all know the journey towards value, right? Like we started at fee for service, and then of course, the end state will be fully capitated kind of a risk arrangement, right? But there's all shades of grays, and it's coming from an operator when I was at Cigna Care Allies with the 60 plus IPAs. They're all along different parts of the journeys, right? Like some of them are only at pay for performance, P for Q, P for P kind of arrangement. Some are willing to move to upside downside, but then, so I think I would say there's still a gradient of the needs, but all things I would say it's moving towards opening we know that we need to manage our ever rising medical costs, right? So all the providers or all stakeholders in the ecosystem are aggressively moving towards value or pay for, even if it's just pay for quality, pay for performance, right? So I think what that allowed us to do is open up the aperture, the reimbursement models for many of these innovators, right? And we'll hear from, Dan about his platform enabling or taking care of care. Will Sam be able to address high cost TI patients? I think those all open up for many of these companies that are innovating in the space. In addition to, of course, we're fully aware of many of the companies in the near term. In order to get revenue traction, probably will need to tap into some of the existing CPT codes under a fee-for-service arrangement. But I think we're very encouraged to see that some of the largest payers partnering with portfolio companies or others are aggressively moving towards a state where we can truly move towards value. And what that allows is it just allows many of these companies, I'm sure you will hear from a lot or others, but I would say for example, the complex maternity, right? Like John, like given that you're an OBGYN, like what the value-based care arrangement, especially be under case rate or even some sort of sub-delegation, allow companies to be able to provide services that goes beyond just the medical care, right? And as a bundle, and without having to wait for establishment of a be it reimbursement mechanism or even just some of the more IT claims like the housekeeping side of things, right? Like for example, Kayaba Care is able to truly bring team-based care for many of these women. It's not just about managing their medical needs, right? Of course, if they are hypertensive, you need to intervene via medical means, but they are also psychosocial. There's a lot of behavioral health needs. There's a lot of substance use disorder, like smoking cessation for pregnant women, but also there's a lot of social needs, right? To prevent, like if a woman is malnourished, likelihood the outcome is going to be bad, right? So it really the innovation in terms of payment model, like from both the public and the private sector side, enable the generation of companies that are like, that kind of, I highlighted in the previous slides, they're only at the tip of the icebergs, right? There are so many more companies that are also up and coming. And as an investor, when we look at companies in this space, like we obviously, of course, we all are fully aware of, like we have to be patient with companies going on the value-based care journey, right? Like when I was at Cigna, we wanted to even internally, years ago, we wanted to innovate on some of the value-based arrangement, but it takes time to update the claims engine, update some of it. So as an investor, we are like, and many of the investors, FLIR especially included, we're patient investors. We know that it's going to take a long term for the companies to be able to move from today's fee-for-service to fee-for-value. But we are keenly paying attention to companies that we do believe that or have that mindset, right? Like to move towards value, because otherwise, from payments mechanism standpoint, it's easy to just get into the fee-for-service mindset, and then as company grows, then they might even tap into some of the old habits of the previous generations of company that just focusing on volume instead of value, right?
Yeah, I think if there's a common thread from what you said, thank you. It's really because we've had speakers actually make the comments that are your companies just trying to take some of the $3.7 trillion spent, for themselves, or they're really trying to lower the total cost of care? And if there's a common thread, and correct me if I'm wrong, in the companies you're investing in, they're trying to do both. They're trying to raise the bar for quality, improve patient access, improve patient satisfaction, and lower the total cost of care. Is that fair?
Absolutely. I think a lot of the care that we're seeing, both when I was on the operating side, but also now as an investor, seeing many of the companies and also talking to some of our strategic LPs, is I think we're all, as a system, we all try to do the right thing. So I know that there are a lot of political rhetorics trying to assign blames on who's like, and one of my professors, I think when I was at HBS, Professor Regina Herslinger wrote a book on who killed healthcare, right? And I mean, it's a little bit of a provocative, like kind of a title, but it was like, based off of like the Oriental Express, right? Everybody has something to do with where we are in the system. I do believe that, having seen on many sides and also consulted for providers and health system, I think everyone by and large, everyone's trying to do the right things, but because of the lack of well-coordinated care, right, as well as the transparency in terms of many of the data, some of the challenges, it led to inefficiency in care, right? So I think for many of the companies in the space, the one we invested in, I'm sure for Dan and Sam will talk about it, is driving towards the proper coordination of care, eliminate unnecessary care or poor quality of care, right? Because you can unlock a lot of value, as like, I forgot the exact stats, like Humana and UPNC, Dr. Welsh Rank, they published a paper like maybe last year or the year before. I'm sure McKinsey and Company, my former employer, also did a lot of research. It just shows how much of the cost in the health system is due to quote unquote like inefficiency, maybe like, poor choice of utilization, side of utilization, like, almost like, I hate to use the word waste, right? Because I think a lot of it's not waste, but I think there's a lot of just efficiencies you can create a win-win, right? Like for companies to do well, and then while lower costs at the same time.
Not to interrupt you, but I want to move on in the interest of time. But as a lean black belt, I actually think it's fine to call it waste because it really is muda. It is. There's waste along the whole continuum. But Paul, do we have time for a question from the group that I know you're monitoring the chat?
Yes, Steve. Or John, I think that we should have the speakers both have Dan and Sam go, and then
all right. Let me. I'm going to move on then. Thank you. So Sam, thank you, Ian. Thank you so much. Sam, we're going to move to you now. It's my pleasure to introduce Sam Holliday, the CEO of Oshi Health. Sam, I'm down in Delaware right now, by the way. Sam grew up not too far from here in Morristown, New Jersey, not to be confused with Morristown, New Jersey, where I was near. He then crossed the Ben Franklin Bridge, I guess, to go to the University of Pennsylvania, where he also was an engineer. He got his BS in clinical engineering, and then went to the Wharton School a few years later and got his MBA. Was a COO for a company called Fit4D, which eventually became Cecilia Health. And if I have it right, I think what that company did, Sam, was improved adherence for medication and patient outcomes regarding chronic diseases, particularly diabetes, through a telehealth approach. Then you also got into the entrepreneurial world, it sounds like, and started working with a lot of startups, incubating them as either founder, consultant, or advisor in a lot of different areas, actually, clinical trial sectors, digital health, food as medicine, interest of mine, and healthcare services sector. And now you're the CEO of Oshi Health, which is sounds like it's revolutionizing the way people with chronic GI conditions receive their care. So if you don't mind, Sam, tell us about yourself and about Oshi Health.
Yeah, thank you for the opportunity to share what we're up to in our story. Definitely whole career in healthcare, as you said. Also worked for an electronic health record company on population health, helping build some of the early tools to enable providers to measure quality, coordinate care, engage patients in their care. All of those pieces have sort of added up to what we're doing with Oshi. So let me share my screen here. All right, hopefully that came on. Is it sharing?
Yep.
Okay. At Oshi Health, we are providing life-changing care for people that suffer from GI conditions. And I'm proud to say those are not just our words. We've actually had members tell us that we have changed their lives, which is what it's all about at the end of the day. You mentioned my work in diabetes, and what I saw clearly was the role that food has and lifestyle, in addition to using medications effectively to improve outcomes. And that there were good correlations between improving blood sugar control and reducing total cost of care. Just addressing the medication side, you can make a difference, but you can really change someone's life if you can help them change the way they eat. And there's a company called Virta Health that has, had the tagline of reversing diabetes. They actually get people to sub-diabetic blood sugar levels using food as the primary intervention and actually taking people off medication. And I saw that happening as I was working in diabetes, and it collided with my family experience. My mom has irritable bowel syndrome and had seen a gastroenterologist, had been told about something called the low FODMAP diet. FODMAPs are different sugars, and there's a lot of evidence that about 60% of people, if they can change their diet to remove the FODMAPs that are triggering their symptoms, can see meaningful improvement in their quality of life, reducing their total cost of care and making it a better experience to get the care. So my mom hears about this. She's given the one-page handout. You either get a one-page handout of paper or a 30-page, which is totally overwhelming. That's sort of how we do it in healthcare, to tell the patient, go do this. And I think what Virta showed was you could take a ketogenic diet, which lots of people would say, oh, well, nobody can stay on it. But if you're actually there for them day to day, they do stay on it and they get these massive improvements. And so the light bulb went on for me because my mom went and figured it out. Now, she's also an engineer, a trained cook. So she had this tool set to go figure out this dietary approach. She goes back to her gastroenterologist a couple months later, and he said, what did you do? I've told hundreds of people about this, and you're the first person to ever figure it out. And I heard that and I said, that's crazy. Why is it acceptable to you that the other, hundreds of people, you just keep telling them what to do and nobody's getting any better? Virta has shown we can do this differently and actually get the outcomes that match the clinical trials. And so the light bulb went on for me, like, would a Virta model work in GI? And my sister has Crohn's disease, so a more severe condition. And her challenge was really, she lived in Connecticut actually for many years, and struggled to find a gastroenterologist who would understand who she was and what she did day to day and actually tailor recommendations to things that she could actually do. She found lots of the recommendations to be things that just wouldn't work for her in her life. But it was too infrequent of a session with them. Lots of the things were too expensive, so there was an affordability issue. And so all of these things collided to say, can we redesign GI care from the ground up? And that's what we're doing at Oshi. So we provide diagnosis and treatment for GI conditions. So there's lots of, what are called in the employer world point solutions out there. They're giving people information. They're giving them tools to track their symptoms. We don't think that's enough for a majority of people. We think you actually have to bring somebody the whole care team they need with really frequent touch points. And you actually need to make sure it works and ask, is this making you better? Is this giving you control to sustainably make these improvements in your life? And so that's what we do at Oshi. The three tenets that are here, everything we're doing is based on gold standard evidence in clinical trials. All of it was done in a brick and mortar setting. But it showed that integrated care, where you actually put all the providers on a team. So in our case, it's dietitian, psychologist, gastroenterologist, nurse practitioner who can take more time with the patient. In some cases, a social worker. And, in our world, we use health coaches. If you put them all on a team to solve this problem and you deliver integrated approaches based on each individual, you get better outcomes. We've taken that and translated it. Ian talked about virtual first. When we looked at what works, most of it is conducive to a virtual care interaction. And so that's how we've built our care model. It's clinically proven and it's whole person. So we are taking time to unpack what's going on. The psychological interventions for GI, a lot of people don't realize that anxiety can trigger GI symptoms. The signaling between your gut and the brain is among the strongest signaling pathways in the body, and it can get dysregulated. So there's trauma-informed care. A lot of early childhood trauma can actually cause lifelong GI issues, and you can undo the challenges in the signaling there with cognitive behavioral therapy, hypnotherapy, even things as simple, John, we were joking before, as diaphragmatic breathing. It can impact the nerves that do a lot of this signaling and really reduce symptoms. But these are really underutilized interventions in our healthcare system. And that sort of brings me to the third piece. Why are those underutilized? Well, fee-for-service doesn't pay for them. So I'm sure that's not shocking to lots of people. For whatever reason, we will pay for a dietitian to work on diabetes, but we won't pay for a dietitian to work on GI conditions. Why? There's perfect evidence that it works. Same thing. You actually, as a psychologist, cannot get paid to deliver these CBT interventions if your primary diagnosis code on the claim is GI. Why? Right? So the problem here was not that, somebody said it earlier, bad actors in the system. It was the way we're paying for the care doesn't incentivize the things shown to get the best outcomes, best experience, and lowest cost. It incentivizes more procedures, more medications, many of which are only moderately effective. And so our goal is to really redesign this. And you mentioned it, improve access, improve satisfaction, actually measure the outcomes and improve them. The quality of life is huge and lower total cost. Okay, so that's trying to sort of set the stage for the whole picture. This is a way bigger population than people realize. So it's actually more than twice the size of type 2 diabetes. There's 70 million people diagnosed with a digestive disorder. The more severe ones you'll hear about and many employers are aware of because of the biologic drug spend is Crohn's disease and ulcerative colitis. The biggest group from a population perspective is the functional, and they've actually renamed these gut-brain disorders, sort of reflecting that these are psychologically driven in many cases. So things like irritable bowel syndrome, constipation, chronic diarrhea. And then there's also GERD, which I think a lot of people know and primary care will treat with PPIs. And finally, the AGA just came out and changed the guidelines and said, hey, we shouldn't keep people on PPIs forever. Not really how they were meant to be used. And so, a big opportunity there as well. I mentioned this. There are very few quality measures for GI. We don't even ask the most important one, which is we don't even ask the patient and report, are their symptoms better? And do they have control of their symptoms? Meaning, do they know what to do to keep their symptoms down going forward? And so we're asking those questions. We're actually showing tremendous results on improving both of them. There's very little support between the infrequent visits. There's no access to diet and psychological, and there's really little focus on value and cost. What I should highlight, what GIs really are paid to do and trained to do is procedures, colonoscopy, endoscopy. And so they spend a lot of their time in the endoscopy suite. A lot of the care for things like IBS, once a procedure is done, they rule out the bad things. They don't really have much to offer other than medications that work for maybe 10% of the people. And so they'll cycle through medications. It takes a really long time to get to any kind of good resolution. So it's driving high utilization, both of visits, hospitalizations, deaths, really high spend. It's actually bigger than heart disease, mental health, and trauma in this study. Increasingly, we're hearing from employers that this is popping up in their top 5, sometimes top 3. We just announced a partnership with Quantum Health. They're doing that because it's the number 2 driver of calls to their care navigation. And it's the number 2 driver of cost across all their customers. And so they said, wow, okay, this model makes perfect sense. We should partner and bring you to our employer customers. And it's driving really poor experience and quality of life. So in our patient population, 80% in their baseline assessment said dissatisfied or neutral with prior GI care, and 80% said it didn't actually resolve their symptoms. And we flipped that on its head. Big absenteeism issue, problems for purchasers, high cost, lost productivity at work, and on the patient side, quality of life. It's stigmatized. I should mention that, like, people don't talk about this, which is why it hasn't gotten as much attention historically. And the access, the wait times to get into GI are way worse now post-pandemic because the GIs are trying to catch up on all the procedural volume that got paused during the pandemic. And so this was a problem pre-pandemic. Now it's much, much worse. Try to get in and see a GI as a new patient, and you will see this. So we put all the people, care team that a patient needs in one place, bring it to them through telehealth. We give them tracking tools to track their symptoms, track their food intake, their bowel movements, and we use that to inform iterating through dietary and psychological interventions until we solve the problem. And when I say iterate, we're on average meeting the patient every 2 weeks. So think about that compared to every 3 or 6 months in the traditional fee-for-service world. You need this high-frequency touch. We're not asking someone track your food and in 6 months try to remember what you ate, how your bowel movements were, and try to unpack all that data. We're doing it in 2-week increments so that we can really iterate quickly to the resolution. This is our care teams, gastroenterologists led, nurse practitioners are the quarterback, dietitians, psychologists who are real experts in the GI specific interventions. These are not generalists seeing a GI patient, 1 out of every 10 or 15. They're only seeing GI patients and really honing in quickly on what works for these people. And a health coach is an accountability partner. Not shown, but really important, is a care coordinator. And that's because we can deliver much of this through telehealth and through digital tools. But the reality is this: we have to sit and complement the in-person care capabilities. You can't do a colonoscopy fully virtually yet, although there's cool technology from Medtronic and others going in that direction. we need good partners in the local market on the GI side. They're really well-tuned, well-oiled machines for the procedures. They all have infusion suites for the biologic medications. They're really important when there is an alarming symptom that we detect and we say this needs an in-person workup. We don't need to own brick and mortar facilities. We can really just find the best place for the patient to get that care. And part of best place in our world is value, right? So thinking about who is going to address this patient with value in mind, who's going to be a good partner in getting the best care for this person. And then importantly, on the primary care, someone asked a question about getting upstream in the chat. That's what we want to do. The biggest impact we can make is if primary care refers to Oshi prior to referring to the brick and mortar gastroenterologist. A pretty shocking stat, if you look at an average GI clinic, their number of visits to number of procedures ratio, 1-to-1. Think about that for a second. Some of them have even gone to scheduling the procedure before they even meet the patient. So, like, we can get upstream of that. About 40 to 50% of those procedures are avoidable. Procedures average cost anywhere from, on the very, very low end, $1,500 when you factor in anesthesia, facility fees, right, everything else. Mine here in New York City, where I live, was about $5,000 at one of the health systems. So the very big cost avoidance opportunity. And we're following the clinical pathway. Actually, many of those procedures are not done following the positive diagnosis pathway. It's a myth that you need to rule out IBD and cancer to diagnose IBS. That's actually not how the guidelines are written, but that's the behavior. And they'll code it as chronic constipation so they can justify doing the procedure. So it's just an interesting space when you unpack it. And so this is what we can do. We can get somebody's symptoms improved and controlled in the time they'd be still waiting to get that procedure done, with that procedure yielding no answer at the end of it other than good luck, go find a dietitian and a psychologist, or try low FODMAP. So value story, and I know I'm coming up on time. So better care, better outcomes, bigger savings. We're avoiding these procedures. By getting ahead of these conditions, someone also asked about preventive care. That's what we do. We're delivering the preventive approaches to avoid escalations that drive the really high cost. And in some cases, we're able to reduce or actually take people off of medication safely. We have to be careful with biologics, but things like Linzess. This is now advertised on national television for IBS. It costs about $4,000 a year. You don't need it if you use dietary and psychological interventions, but it's very commonly prescribed. And so you can get the picture of how the cost is out there to be avoided while also improving the outcomes and the experience. We've been studying this with a national payer in Pennsylvania, Florida, and Texas, measuring satisfaction, measuring are the symptoms getting better and being controlled, quality of life, and pretty soon we're going to have the match control analysis using claims data to prove the economic impact. But here's our estimate of the economic impact. So if you look at the bottom of the screen, we've taken 10 people. This is about 260 members that had made it far enough through the study to cut the outcomes. 10 people taken off medications, including 2 on biologics. So one that was incorrectly put on Humira. So think about the cost savings from taking somebody safely off Humira, right? That probably paid for this entire study. Another that was on a different biologic but was put for no reason on double the starting dose. Was on way too much medication. We scaled it back safely, no change in outcomes or clinical measures, and really reduced costs. But also that patient doesn't have to go 5 extra times a year to get injected. So just like quality of life, your schedule, your family, that's more time with family, more time with work. And then avoiding many procedures and just not even bothering to prescribe the medications because we use dietary and psych instead. And the satisfaction on the top is totally juxtaposed to what people reported coming in, and we're actually getting them controlled. Contracting is the next thing. So we are working to get ourselves in network, going sort of state by state, trying to get the plans to set us up in network and negotiate a bundled case rate. As I mentioned, a lot of the things that we do are not reimbursed in fee for service. But you just saw the economic impact of this care model And so we're really working to convince the plans that they need to pay us in a slightly different way. This is the move to value, the whole theme of this event. And we'll put some of those fees at risk based on showing these outcomes, because we know it works and we know how to avoid the costs. And what we eventually want to do, as Ian mentioned, is move, down that continuum toward actually taking full risk for the GI spend. That's a multi-year process to build the capabilities, the trust, the data, but that's where we're headed. And I will stop there.
Great, Sam. I wish the late Clay Christian was here and could hear these presentations, because you guys are really filling a need and clearly disrupting the current model, which is broken at best. I'm going to ask you one question, Sam, because I want to move on to Dan in the interest of time. But so I think what you've talked about, we could talk about 10 other diseases that I can think of in about 2 minutes that fit into the same category. That, boy, with some nutrition and some behavioral health, we could really reverse chronic disease, prevent diseases going forward. So I guess I would ask you, what do you see as the next few Oshi projects, or maybe a different company? What other chronic conditions? And I don't want to give you the list I have. Tell me what you think.
Yeah, it's so there are, like you said, other condition areas that we've looked at. The reality, though, there's so much need for this just in GI that we have a multi-year journey to scale this nationally. Our ambition is to be available in every single state, so that a national scale employer can offer this to their people all over the country. And we have one of the largest employers in the country who's sort of like, can you get there faster? We want to do this. And we were unfortunately restricted by state licensure and all those things. So.
I'm sorry to interrupt you. I apologize for that. Your play is to you market yourselves directly to employers. So if I had a GI problem or a family member, I can't call Oshi myself, right? It would only be through my plan, through my employer.
So yeah, how does the member sort of get coverage? So we are working to get payer density. So as many of the national and regional plans as will cover our services, that will actually let us market broadly. And we will put up a cash pay program as well for those whose plan or employer doesn't cover our services. We have people every week coming in asking if they can just pay us out of pocket. The demand is out there. So.
Absolutely. Sam, thank you so much. I am going to move on, and we'll hopefully have time at the end for questions from everybody. With that in mind, I'm going to move on to Dan Blumenthal. Dan, thank you for joining us today. Dan is the CEO of Novocardia, another Ivy Leaguer, went to Harvard Medical School, Harvard Business School. Dan, I'm wondering if you've ever been out of Boston, actually, because then you did your residency at Mass General, your fellowship at Mass General, you're a faculty member at Mass General, and I'm guessing you were at Mass General this morning seeing patients. So God bless you.
I lived in New York. I lived in New York for a few years after college.
But I'm going to guess you don't root for the same baseball team that I do. I'm just guessing.
No, I don't. Yes, no, I don't. Yeah.
But thank you for joining us. So Dan has a great career as a cardiologist, but he's published many papers, really working on innovation in payment design and quality improvement in cardiology. Shocking, they're actually looking at data and outcomes here, guys. This is really, who would have thunk it, right? And you worked for a while for Devoted Health, which was a investor-based Medicare Advantage insurance company, if I understand correctly. But now you've founded a company called Novocardia, and we want to hear more about it.
Great. Well, thank you. Thank you, John. And it's really a pleasure to be here. I'm just going to share my screen. So our mission at Novocardia is to improve the quality and value of cardiovascular care in the United States. And, first of all, I think, Sam did it's incredible to hear about the innovation that is occurring in the GI space. We have taken a slightly different approach, but there's a lot of similarities between how we're thinking and about innovation in our specialty, and it was just great to kind of understand and see some of those things. Our mission, as I mentioned, is to improve the quality and value of cardiovascular care in the United States. And we're taking an approach that involves building a management services organization and partnering with independent cardiology groups and helping them to deliver high quality, high value care at scale in select markets in this country. And really, we have kind of a 5 aspects to our management services organization. We are providing traditional practice management services, and I would say non-traditional practice management services that many cardiology practices in the community need, but don't often have access to. And I'm talking about human resources and marketing as in addition to the core back office services. We help them with thoughtful strategic development and growth, and often through partnerships with risk-bearing primary care groups in their communities, and through the development of care delivery locations in lower cost sites, because about 50% of cardiology care is currently delivered on hospital campuses. We offer them the support for the development and delivery of high value clinical programs that traditionally community practices haven't offered. And those include, evidence-based clinical protocols and delivery models, which are virtual first for heart failure and prevention and wellness and atrial fibrillation. And we recently, and I'll talk a little bit about this shortly, but we recently launched a virtual first heart failure program at one of our 2 practices. We see that as an example of a scalable approach for the use of technology to deliver care in a high value, low in-person touch way. We also offer access to other types of technologies and analytics. So we're building our own data and analytics platform, which will help us to deliver to cardiologists the data that they need to evaluate their own clinical and operational performance, and ultimately their own cost performance. And also we're developing a set of actuarial models that will help us to contract with payers and risk-bearing primary care groups. And finally, kind of pulling that all together, you have the goal here is to create kind of a market level value-based care ecosystem, which combines the new clinical programs, which are high value in general and improve quality, are evidence-based, involves the delivery of care through technology when appropriate, and data about performance, and the actuarial modeling services that practices need in order to be able to contract with payers and other risk-bearing entities, and then the contracting expertise. And so we provide practices with the ability to leverage our contracting leader, value-based care contracting leader, to engage with payers and local risk-bearing entities to develop the right kinds of risk contracts. So we are, as I mentioned, building really, I think physician leadership is really critical to enabling the success of our organization. And so I wanted to kind of highlight that because it's something that I think is often overlooked, but is critically important to success in not just the startup environment, but really in any clinical services organization. And then, the use of technology, I think, again, a common theme throughout these presentations, but we see a kind of a role, we see technology as being complementary to in-person care in cardiology. And this is, I think, perhaps one of the ways in which cardiology is slightly unique. You're dealing with people with complaints that could be imminently life-threatening, but could also really be nothing. And, could be anxiety, chest discomfort, could be, in a cardiologist's mind, often it becomes, the first through fifth diagnoses are impending heart attack. But the vast majority of people who complain of chest pain really don't have ischemic heart disease as the underlying cause of that chest pain. They don't have a pulmonary embolus. They don't have something that's imminently life-threatening. And so if you can start to think through a set of thoughtful approaches for how you can use technology as an initial screening tool, or a technology-enabled platform as an initial screening tool to help you figure out which patients really need to be seen in person and which ones don't, you can then really start to make inroads when it comes to keeping people with chest discomfort that you don't think is related to their heart out of the emergency room, right? Even if it just means that they can come into your clinic and be evaluated rather than going to the ER. That's results in big cost savings and an improvement in quality of life and, time saved from waiting in the emergency room to see the doctor after you get your EKG and your cardiac biomarkers and everything looks okay. So there are ways in which you can use technology, I think, to take care of sick patients. And then there are also ways that you can use technology to deliver, or patients with acute complaints. And then there are ways that you can also use technology to deliver longitudinal evidence-based care throughout, or to patients who really, benefit from a high-touch, remote-first model to ensure that they're on the right medicines, to ensure that they're getting the right coaching and counseling, to ensure that they understand their illness. So we're working kind of on both of those fronts to use technology to enable how we deliver care in our markets. We currently have 2 practice locations. So we have a large practice in Northeast Florida. So we've launched in Florida first. We have a large practice in Northeast Florida, which has 15 cardiologists and now 12 advanced practice providers. And we've also partnered with the largest independent cardiology practice in Florida, which is called My Cardiologist. And that practice has 27 cardiologists and about 8 advanced practice providers. And we take our partnership approach involves actually an acquisition of the practice. So it's a deep investment in the practice's success. And I think to transform care locally, we believed very strongly that you really need to be deeply invested in the success of the practice, and that for us meant you have to, and you also have to be able to control what is happening in the practice. And for that, for us, that meant actually, making a financial investment in the practice. We're currently treating about 47,000 unique patients. About 70% of those are Medicare patients. Half, I would say actually probably 2/3 of those Medicare patients are Medicare Advantage patients. And 1/3 are traditional Medicare patients. We're in markets, and the market selection for us is actually critically important. So we have a very rigorous market selection process. But we're in markets, for example, where we know that there is opportunity to actually push forward with partnerships with accountable care organizations and risk-bearing primary care groups relatively rapidly. In Southeast Florida, we're in advanced discussions with a very large national risk-bearing primary care group to develop an exclusive relationship to serve their members. And so we see that as one mechanism by which we partner and coordinate with value-oriented primary care physicians. To do that, I would say we realized, and as we were doing market research, we realized that we needed to have brick and mortar practices. We needed to have clinicians on the ground. These groups, and this was part of what I learned when I was at Devoted, because I was the associate chief medical officer and the national medical director for the health plan. And so I was interacting with the chief medical officers of 30 or so risk-bearing primary care groups in Florida. They weren't interested, at least at that time, and really still aren't interested in a virtual first care delivery model. They want their patients to be seen in person and evaluated physically. And so for me, that was actually a formative influence in terms of thinking through the care model. Again, cardiology is quite different than other specialties in that respect, in many respects. But we learned from our market research that was really critical for them, and they're taking care of a lot of dual eligible patients, people with many chronic comorbidities, many of whom have limited English proficiency, many of whom have still have limited ability to actually access even just a telehealth platform, and so that has influenced the decisions that we made about brick and mortar versus virtual. I think that the work that we are finding that we're actually engaging in these practices involves not just kind of rolling out clinical programs, but also hiring advanced practice providers. So for this first practice in our first partner practice in Northeast Florida, we hired 7 advanced practice providers in the first 3 months. They had about 15 cardiologists and maybe six advanced practice providers. And so that ratio becomes a very important one to us. We're trying to actually get it closer to 1-to-1, if not on the, on a kind of 1 to 1.5, 1-to-2 ratio. Cardiologists are a bit resistant to that notion at first, but if you kind of give them some exposure to, working with trained APPs, and so we're building set of training modules for advanced practice providers, you can actually they're still coachable. Even the older, even those who are in the middle towards the later stage of their careers are open to working with APPs once they see advanced practice providers, once they see that they can really provide value and help them to kind of decompress some of their clinical responsibilities in a very effective way. So, our value proposition, again, first, and I didn't really talk about the high level economics here, but cardiology right now, or at least actually about 5 years ago, accounted for $320 billion of direct medical spend per year in this country. And that number, according to the American Heart Association, is going to go to about $800 billion by 2035. And that does not include indirect medical spend, which is another 300 or so billion by 2035. So it's over $1 trillion of costs to our system. If you look at where that money is spent, about 50% of it is spent on hospital campuses, that's not surprising, given that 83% of cardiologists in this country are now employed by health systems. And so we have undergone, if you roll back the clock about 15 years to 2008, 85% of cardiologists in this country were in independent practice. And then a few things happened. The Affordable Care Act, which again, I'm a huge proponent of, a big fan of, I believe very deeply in. But the Affordable Care Act created new reporting requirements, which which some cardiologists found to be onerous. Medicare reduced reimbursement, again, not a bad thing. I think cardiologists were certainly being overpaid for stress tests and echoes and caths, but reduced reimbursement by about 40% in 2008, 2009. And perhaps, actually unequivocally, I think the most important driver of the consolidation with health systems has been just a frenzy of M&A activity, which health systems have led in order to try to shore up referral lines for profitable procedures. What has happened, however, is that cardiology practices have found it that remain independent have found it harder and harder to compete in a fee-for-service world. They don't have the bargaining power that health systems have. And they often get squeezed. And when they get squeezed, they all have a threshold at which squeezing them again leads them to go look for a partner. And that partner traditionally has been the health system. And so in the course of having conversations with groups across the country, it's become very apparent that, these groups exist on a spectrum from being, we're still okay, to we're teetering on the edge here, and we're really thinking about partnering with the health system that's in our market. And kind of one more squeeze on reimbursement will lead to partnership with the health system and employment. We're trying to short circuit that cycle and preserve cardiology as a source of high value care in the community, and also to then kind of get out in front of what we see to be just an inevitable transition towards value, given who cardiologists take care of. 70% of our patients are Medicare patients, and 43% of Medicare patients right now are in MA, and another, and a quarter are in ACOs or direct contracting, and that number is going to go to 90% by 2030. So whether cardiologists like it or not, they're going to be forced to actually have to reckon with this transition towards value. And many of them know it at some level, but they don't know how to make that transition. And so, we are fundamentally trying to help them along and make them successful in a sustainable way in a world where they're going to probably be getting 30 to 50% of their reimbursement through value-based care arrangements in 2030. We also
interrupt you for a second.
Yeah, of course.
I want to make sure we get okay on time, but I have a question actually based on what you just said, if you don't mind. So, because I was going to ask you, I said, so you're competing with health systems to acquire cardiologists, and I believe I used to be one of those guys trying to acquire those groups because I wanted to keep the business in my hospital, of course, because that's how we make money.
Yep.
So you're competing with hospitals and health systems for acquisitions. But to your last point, if you look at a market that has a large primary care group that is doing at-risk work, value-based work, not employed by the health system, but the only cardiologists in the town are employed by the health system, are you prepared as a company to actually say, well, we can start a practice there to help those docs? Because I would think those primary care physicians like, hey, this health system's killing us.
Absolutely. We will, I would say, by the first quarter of next year, have the ability to do that. Yeah, but that is one of the, that's one of the approaches that we're going to take. And actually risk-bearing primary care groups, take a variety, or ACOs take a variety of approaches towards providing cardiology. They all use in-person cardiology. Some have a virtual augment, but even the virtual first groups, as I think as Sam alluded to, need in-person care as a complement. And so some of them bring cardiology in-house, but they're really not built to manage cardiology. And cardiologists can be an acquired taste to manage.
Right. Well, so let me ask you then, and again, I'm interrupting for clarity of your prompt questions, so thank you. So Dr. Schutzer, who's one of our founding members, was able to get 10 orthopedic surgeons from different groups to actually agree to what appropriate DVT prophylaxis is, and what antibiotic to use prophylactically, and how many doses to give, and when to give a transfusion of blood. And doctors, and again, as one of the doctors on the call, I can say that we tend to think, well, I know how to manage my patients. Don't tell me how to do it. We're very independent. There's a tremendous variability in quality and cost in all medical specialties, and especially actually cardiology. Have you had it's a silly question, have you had challenges, but how do you approach the variability in care within groups and between groups?
Yeah. So, I mean, the first answer, so we just had our first kind of, operating. So we've established quality committees for each group. And those quality committees consist of the majority of the people on the committee are clinicians from the practice. We're an early stage company. We raised our Series A in June of 2021. And so there's a lot here that we're still working on, but our plan, I mean, I can tell you what our plan is. Our plan is ultimately to create regional and then a national quality infrastructure. But we as a clinician, right, I want my clinical partners to be invested in and activated to engaged in, right, develop the quality guidelines that they're going to be using. Our job, I view our job over the medium to long term as supporting them to do that work, supporting the dissemination of the products of their work, and then ensuring that it actually can influence care delivery at the point of care.
And
that we have the right incentives in place.
And you give them feedback about how they're doing,
That's right.
so that they can adjust accordingly. Dan,
That's
I want to
right.
be
We have the
sensitive to our time for our guests. Can you wrap up in another minute or so?
Yeah, of course. Yep. So our as I mentioned, so our path to risk involves, in addition to kind of what I see to be probably a few imminent partnerships with risk-bearing primary care groups that involve value-based care arrangements. We're already serving patients from many risk groups in our clinics, and we are over the next 2 years going to be offering a flexible suite of flexible risk arrangements that will enable us not just to partner with those risk groups, but also with payers. And we've engaged with several payers in our local markets, and I think have we've had a fair amount of interest. Those cycles tend to be a bit longer. So I just wanted to talk a little bit about heart failure, and then I can wrap up in a minute or two. So heart failure is the most common cause of hospitalization among adults 65 and over. There is a lot of evidence that has published evidence, randomized trials, prospective outcome studies focused on different types of interventions to drive improvements in health outcomes, reduce costs of care, improve quality of life. We have started to incorporate that evidence base, which includes remote patient monitoring and a virtual first telehealth driven solution for heart failure management, into a longitudinal heart failure program that we developed and launched in our first practice in Jacksonville. Over the first 8 weeks in that program, we've enrolled 100 patients with heart failure from the community. It's we are offering the only heart failure solution in about a 30 to 40 mile radius, because this heart failure program is being offered in St. Johns County, which is in between Jacksonville and Daytona Beach. And we've anecdotally received a ton of feedback about how important it has been in the lives of those patients who have been enrolled. And again, we're in very early days here, but we have incorporated all of the latest guidelines from the American Heart Association and the American College of Cardiology, alongside standardized education and treatment guidelines, or standardized education guidelines, delivered virtually. So this is just what we say be our playbook for success, and I will stop talking there, John.
Well, I could listen to all you guys for hours, but I'm going to turn it over to Paul now, who might filter some questions. And thank you, Paul.
Yeah. So we're not going to be able to address everyone's questions. So our plan is we'll capture these, ask for answers from our presenters, and we'll post them in the Moving to Value Alliance community. But I'm going to start with kind of a selfish question. As you think about where you're going to do business next, what would it take for you to do business in Connecticut? I don't know, Sam, maybe what do you need? You need an introduction to an insurer in Connecticut. Do you need to get introduced to GI groups? And same question for Sam. Or I'm sorry, for Dan. Sorry.
Yeah, so it's Sam. I'll start. It really does come down to coverage. So either one of the local health plans, or a large employer who has a sizable enough population that can support the expense that we have, which is really cross-licensing our clinicians into the state and or hiring and training new staff to support people in the state. Unfortunately, the biggest barrier to us is state licensure. Is there really a reason for it anymore? I'm not going to answer that question. I'm just going to put it out there and leave it open. But it is a barrier to providing the best possible care across state lines.
Great. We typically have somebody, policy maker on this call. I don't see anybody here now, but we'll bring that to their attention. Deanne?
I would vigorously second the state licensure point that Sam made. I think a connection to a payer or to a referral source, and I think in a virtual first world, we could offer our heart failure program virtually, right, from Florida through our existing provider base to clinicians and to patients in Connecticut. And that's an approach that we're thinking about using as we expand into new geographies. So I think, some time, a clear reason to make the investment in getting our clinicians licensed and setting up the connections with the payer and the referral sources. And that probably would just mean some commitment about patient volumes. But ideally, we'd want to, be involved in taking on risk, and then we could, and we could then go from there.
Great. Thank you. Well, we'll try and make those connections happen. You both have talked about just connecting to other members of the healthcare community, and I think you've done a good job covering that. I don't know if there are any comments that you want to make there, or again, kind of same idea. If there's things that we could do to support you, make those connections. Yep.
Yeah. I mean, always to us, the most important is getting agreement to pay for the services. It's easy for us to scale it once we have that commitment.
John, well, go ahead, Dan. You have anything to add?
No, I would second that. I think, access to data too, right? I think, we have the ability to run the analytics to figure out which patients could benefit from, for example, a virtual heart failure program. I think one of the things, to be completely honest, one of the things that we have found in our early forays, into working with several payers, and I used to work for one. This is not a criticism. It's I think a limitation, has been a reluctance to share data with us on their patient population, to sort out where we could deliver value. Some of that could be a trust issue. Some of that could be a lack of understanding of what it is that we're trying to do. Some of it just may be, and I think we are perhaps just a bit early in cardiology. Many of the payers that we've talked to have really just started to turn their attention towards cardiology, and cardiology is so, it's actually, like GI, right? You have 7 or 8 subspecialties within cardiology, spanning cognitive and procedural subspecialties. A payer has to take care of all patients and all aspects of all patients. And it's hard to, if you're a payer, it's hard to make deep investments in really getting into the nuts and bolts of electrophysiology versus peripheral interventional cardiology versus structural heart disease, and where the sources of value there are. So, we find that can become a barrier, because we end up, we talk to the cardiology specialist, but the cardiology specialist may, is focused on the big picture still within cardiology. And so the time investment is substantial to really drive home where we can deliver value.
Dan, to just interrupt, we shouldn't confuse payers with third-party administrators.
Totally, that's right.
Our whole group partly exists to improve that transparency, because it's the employers ultimately who are paying, and employers including state governments and federal government as employers, who are paying the bill. So they're the ones who really should be responsible and should want the data.
Absolutely.
But it's a very close to the chest poker game regarding that data. But you're absolutely right.
And this is not, I mean, I'm being just as transparent as I can be, because we want to try to help the system that we're practicing in to get better. Right. And this is not at all a criticism. It's just I think an observation that we've made over the last year or so.
Right.
Yeah.
Let me take a moment to thank all three of you, and I'm going to kick it back to Paul, who wants to tell us about our June forum. But Ian, Sam, and Dan, thank you so much. I wish I weren't an obstetrician, or I'd love to work for any one of you. Or I wish if I was taking my oral boards again, I'm sure I could call Sam and get some advice before I took the exam, because I'm sure I had some GI crisis that day. But honestly, you guys are great, and thank you so much for joining us today. Paul, I'm going to kick it back to you.
Okay. And again, thank you, John, for doing such a nice job moderating. And boy, we want you to bring your business to Connecticut and help us change the system. And so we'll follow up afterwards and see if we can help you make some of those connections. Our next big event is June 2nd and 3rd. It's transformation, payment reform, and collaboration is the theme. And as I said before, Elizabeth Teisberg's going to be the keynote speaker. We'll have more details to you. Thank you, everyone. Have a good day.
Thank you all, guys. Bye-bye. Have a nice weekend.